All right, well, good morning, everybody. Happy Wednesday. We'll be doing grand rounds and conference today on the same WebEx, so no need to switch over in a little while following Dr. Grimes' presentation. And so Matt, I'm just going to do a real brief introduction, then we'll get rolling with your topic today. I assume you've got your slides and ready to share them up. I see you know the routine. Great. Well, very briefly, Dr. Grimes completed his medical school at the University of Washington and was with us for a few years as a resident here at UW. He left us for a brief stint at the University of Iowa under the tutelage of Brad Erickson, doing a fellowship in reconstructive urology, and came back a few years ago and is now an assistant professor in our department. And as you can see, the topic this morning is about bulbar urethral strictures. So without further ado, Matt, the floor is yours.
All right, perfect. Well, thanks for the kind introduction and thanks for the opportunity to present today on my favorite topic, which is urethral stricture. I don't have any relevant disclosures. So again, this is why I decided to become a reconstructive urologist, is that my favorite thing to do in urology is to turn this urethra into this urethra. And so today I wanted to talk about some of the tools that we have to do that, and focus on the clinical evaluation, diagnosis and staging, which methods we have to treat this problem, and then my thoughts on how we might be able to do it better in the future. So specifically, we'll discuss the epidemiology of urethral stricture disease. We'll talk about the clinical evaluation, focusing on the diagnosis and staging. We'll talk about currently available endoscopic treatments, as well as a recently approved FDA approved kind of new treatment for that. And we'll talk about urethroplasty, which is a huge topic. And so that's part of the reason I decided to focus on bulbar strictures, and specifically focus on kind of two techniques that I see as sort of the workhorse of urethroplasty. And I think by using those two techniques, we can tackle the vast majority, certainly of bulbar strictures. And also, if you understand those techniques, you understand kind of the fundamentals of urethroplasty as a broader technique. And we'll review some of the outcomes we can expect with these approaches, and then I'll give you my thoughts on what the future might hold. So let's get started. So what is a urethral stricture anyway? Great question. The AUA defines it as chronic fibrosis and narrowing of the urethral lumen caused by acute injury, inflammation, or iatrogenic interventions. And so it's important to recognize that everyone kind of knows what a stricture is. It's a narrowing in the urethra, but there's not a lot of good, pathologic level data, nor are there any consensus kind of tissue criteria that we can use to aid diagnosis. In terms of the epidemiology, it's an old problem. So the first treatment was described as early as 600 BC, and the prevalence of this condition has changed. Back in the 1800s, it was estimated to be about 20%, or as I call this, the good old days. In a more recent era, about 20 years ago, we have population level data which estimates the prevalence at about 0.9%. So certainly not the most common urologic condition, but also not the most rare either. So it's definitely out there. And it's an expensive problem. So total annual expenditures back in 2000 were about 191 million, which is high. And that's because this is a procedural problem. We need to do usually kind of expensive procedures to take care of these patients. And then quickly, one kind of misconception that I thought I would try to clear up. So it is often stated or misstated that urethral stricture disease is more common among younger men. That's actually not true. So there's a couple of cohort series that estimate incidence, which show clearly that there's an inflection point around age 55. And so the incidence of urethral stricture, best that we know, actually rises with advancing age. However, it is true that stricture disease is a more likely diagnosis in a young man presenting with LUTS than in an older man. So just a finer point to clear up. Let's switch gears now and talk about the clinical evaluation. So anytime the AUA has a guideline, I think it's a good idea to either follow it or have a good reason why you're not. And especially for the residents, I'll highlight this because I often, in my practice, will kind of skip to the end here and do the diagnostic study. But that's because a lot of people have already done other things, and the pretest probability of having a stricture in my clinic is pretty high. So the minimum initial evaluation is a history and physical and urinalysis. That's it. If there is concern for stricture disease, then you can do non-invasive testing, including validated questionnaires or PROMs, as well as non-invasive uroflorimetry and a PVR. And then if you have clinical suspicion for a stricture, that's when you get into the invasive diagnostic testing, such as a cysto or a retrograde urethrogram or urethral ultrasonography. So sorting out which patients might have strictures can be challenging because they present with nonspecific voiding symptoms. And so these are LUTS patients usually, and it's on us to figure out what the problem is. So the most common presenting complaints are decreased urinary stream in 50% of patients and incomplete emptying in 27%. So not particularly helpful in terms of distinguishing these from, say, a BPH patient. However, a large study of 611 Canadian stricture patients found that the most common presenting complaints were LUTS, not surprisingly, but two that kind of stood out that were a little bit higher that might get your antenna up are people who present with urinary tract infections or have that as part of their history, and pain is another one that kind of sticks out that might help you distinguish these from more kind of garden variety BPH or voiding dysfunction patients, if you will. Other key questions that I think are important are, what is their prior urologic history? Do they have any prior history of sexually transmitted infections? Have they been radiated? Have they had any prior procedures? What's their erectile status? And what is their fertility situation is an important question. And I think it's helpful to know if they sit or stand to void. That's more for kind of surgical planning. And then you want to make sure you capture their past surgical history, including any hypospadias repairs, circumcision, or a prior urethroplasty. A physical exam, we need to do a thorough GU exam, but we need to assess their circumcision status. Is their meatus patent? Do they overtly have lichen sclerosis? Do they have a hypospadias? I always look for incisions. I've had more than one patient tell me they've had no prior surgeries, and then I examined them and they had a buried penis repair. So these kinds of things can be, you got to do a physical exam. So that gets us to kind of the last step here, which is, invasive testing. And there's some discussion and a little bit of controversy about how best to proceed. And here's what I think makes the most sense. So personally, I think the most pragmatic way to proceed is that if you were trying to answer a diagnostic question, i.e., does the patient have a stricture or not, I think cystoscopy is the way to go because it's simpler, it's faster, it's more comfortable for the patient. And if there's no stricture, then you can assess the rest of the lower tract. However, if the patient either has a known diagnosis of a stricture or you think that it's very, very likely that they have a stricture, then retrograde urethrogram is mandatory. It remains the cornerstone of urethral stricture staging, and I think it's required before you consider any elective intervention, and the AUA would agree with that. So one thing that often comes up is, I get referred patients who've already had a retrograde urethrogram, and so the patients and their insurance companies will sometimes ask, do you really need to do another rug? And well, here's an example of an outside retrograde urethrogram that I saw recently. So as you can see, maybe not the most helpful study. And so for that reason, I, with rare exception, do my own retrograde urethograms and will often repeat them if they've been done previously. And I think that the reason for that is that it can be kind of tricky, and especially if you don't do it often. And it's also critically important. So I'd like to spend a few minutes just discussing how to do it, as well as some helpful landmarks. And so here's kind of some do's and don'ts for retrograde. So you do want to position the patient like this, top leg straight, bottom leg bent, and have them in an oblique position. You don't want to do this supine because you can't see the turn of the bulb, so it's not a helpful study. You do want to put the penis on stretch, kind of more than you think you should, and you don't want to compress the urethra. But sometimes people will use like a Raytec, or they'll kind of grab it with their fist, and that can make it difficult to interpret a retrograde. I like to use cone tip catheters or angio catheters. I really don't think you should place a Foley catheter or dilate the meatus to perform a retrograde, because this can traumatize the urethra, and also it can obscure a distal stricture. You need to get contrast into the bladder, and if there's any question, you should use antegrade maneuvers, i.e. having the patient attempt to void with a full, after putting some contrast in the bladder. So here's a normal rug from a patient that got lost and wandered into my clinic the other day, who has a normal urethra. And so want to just go over some helpful landmarks. So the first landmark to appreciate is the external sphincter, which is really just the pelvic floor. And so this should be where the pelvic floor is, right, up in the pelvis, and kind of oriented in this fashion. So if you do a rug and you think that the sphincter is here and it's kind of going like this, that's not right. It's here. And that usually lines up with the obturator foramen. And in this patient, he kind of illustrated that nicely, because in the first picture, he was kind of clenching down his external sphincter, and then he relaxed and allowing the retrograde flow to fill the bladder. So you can kind of clearly see that structure. The other helpful landmark is the lesser trochanter, or the femur. And this, I think, is a pretty good kind of ruler for the distinction between the bulbar and the penile urethra. It's not perfect, but it's a bony landmark, and so it's more consistent, especially in obese patients, as opposed to trying to find the scrotal shadow and so on. And so kind of returning to this rug here, we'll see, well, okay, we can see the urethra pretty clearly. There's the external sphincter. And using the lesser trochanter, that means that this is probably the bulbar urethra here, shown in blue, and then the transition to the penile urethra somewhere in here, shown in green. And then the last landmark that I'll kind of call out is it's often hard to estimate the length of strictures, and you can't use the little measuring tool on PACS because it's not calibrated. And so one kind of rule of thumb is that the sort of cortex to cortex difference of the superior pubic ramus is like about 1 centimeter in most men. So that's pretty helpful, so you can kind of use that as a ruler, if you will, to sort of eyeball and estimate, or sometimes literally measure. And so again, I think retrograde is critical for staging of the stricture, which is going to tell us what our treatment options are and inform how we manage this. And so this is a kind of a simplified schema of a validated urethral stricture staging system called the LSE system, which stands for length, segment, and ideology. And I won't belabor the kind of finer points of this, but it's modeled after the TNM staging system, meaning that as the numbers get higher, the disease is worse. And so you can see that length, shorter strictures, less than 2, 2 to 7, greater than 7. So as the length increases, the number increases, the stage increases. Segment, bulbar strictures are usually easier to manage than, say, a stricture involving the entire urethra, and so on. And so I think this is a helpful way to approach it, even if you don't remember all of the kind of sub-staging. If you can kind of remember this schema, you'll remember to look for and to kind of describe the stricture in a helpful way. And also, this has implications for management. So just like telling an oncologist that someone has T2 bladder cancer implies a certain treatment pathway, and you're already kind of thinking about what you might do for that patient, telling me that someone has an L1S1 stricture means a different thing than telling me that someone has an L3S3 stricture, right? I'm thinking kind of very differently about how I might approach that patient. So now that we've established a diagnosis of urethral stricture disease and staged this as a bulbar stricture, again, we're kind of focusing on bulbar for this talk. So what do we do now? Well, sometimes I joke that I like stricture disease because there's really just 3 options. We can observe it and kind of accept the morbidity associated with that. We can pursue endoscopic interventions, or we can do a urethroplasty. So seems pretty simple, right? So how do we decide? That's the hard part. So let's review each of these interventions, and we're going to kind of focus on endoscopic versus urethroplasty. So again, the AUA weighing in. The AUA recommends endoscopic treatments for index or first-time treatments of a short, less than 2 centimeter bulbar stricture. So first time, short, in the bulb, and for urgent situations. And so I might add to that, agree with that, and add, also for patients who defer or refuse urethroplasty, either because they're not, or because they're not fit for surgery, or in the salvage setting. And so I think that, we'll talk some more about this, but I think endoscopic management certainly has a role, kind of outside of these more strict criteria. But we need to understand it. And so where do these recommendations come from? So regarding length of the stricture, there's these data come from a RCT performed in South Africa, comparing DVIU and dilation, actually, and it shows that strictures that are less than 2 centimeters have a significantly higher success rate of about 60% at 4 years, compared to strictures that are longer, more than 4 centimeters, which is about 20% at 4 years. And so there's been kind of many other examples of this in the literature, but I call this out as kind of the seminal series on this problem. So we know that longer stricture or shorter strictures respond better to endoscopic treatment than do longer strictures. Principle one. Principle two is like real estate: location, location, location. So many retrospective series have shown that endoscopic treatment is more successful in the bulbar compared to the penile urethra. And here's just one example, again from the 90s, which was kind of the heyday of DVIU, showing a higher success rate for bulbar strictures at about 42% compared to penile at about 16%. And so if strictures, if endoscopic treatment works, but the problem is that it isn't always successful, can we just do it over and over again? Well, you can, but you shouldn't expect it to work. And so there's pretty clear clinical evidence, again, from some randomized data from the late 90s, showing that if we dilate strictures over and over again, we see kind of a decay of response to that, meaning that by the time you get around to your third DVIU, patients will fail by about 18 months, almost exclusively. And this has been replicated kind of in probably the most frequently cited study is from Santucci in 2010, who sort of replicated this with very robust follow-up in his practice, showing, again, serial dilation is essentially futile in terms of being a definitive management strategy. So short strictures respond better, bulbar strictures respond better. We know that your first shot is your best shot, and after that, it's more of kind of a maintenance protocol. And so what about technique? Does technique matter? Should we do DVIU? Should we do dilation? Again, we have some randomized data to help us from the 90s, which showed that DVIU and dilation are roughly equivalent. And this has, again, been kind of replicated in more modern series. And so what about side effect profile? Well, I think that DVIU has a higher associated morbidity than dilation. And if you just look at, this is a summary of the slide that I stole from a colleague of mine who's down at Baylor. But there's some serious complications that can occur with DVIU, and I've certainly anecdotally I've seen this out there in the real world. Hematomas, hemorrhage can be a problem. Scrotal edema. We've even seen a case of penile necrosis, actually, kind of a focal area of necrosis. And so I think it's not necessarily a benign intervention. And dilation, conversely, has a very low morbidity associated with it. And so I think in the face of, potentially higher morbidity with DVIU and a similar response, then what I take from this little tour of the literature is that we favor dilation. And so what I do in my practice is it's almost abandoned DVIU, except for kind of certain specific situations which we can talk about, at least in the treatment of anterior strictures. I do the vast majority of my dilations now, especially in the COVID era, in clinic under local analgesia. You can do this under cystoscopic guidance. 24 French balloon takes about 5 minutes. And so I think that this is kind of the way to go in my mind is to dilate. And we can usually keep these patients out of the operating room, which I think is good for everybody. So, paradigm. Can we augment the success of endoscopic treatment? So if the problem is recurrence, can we reduce the recurrence rate? And the answer to that is yes, probably. So there are a couple of evidence-based ways to do this. The first is that we know that doing intermittent self-dilation, or CIC, delays stricture recurrence. We have 2 RCTs on this, again, both from the 90s. Which compared, so both of these compared DVIU alone to DVIU plus some duration of intermittent catheterization. And notice the difference here is that in the first study, people did dilation daily for a year after DVIU. In the second study, they did it for 3 months. And then both found that DVIU only, success rate at a year was about 25% versus about 20%. And then in the guys who kept catheterizing, we were able to increase that to 80% if they just kept catheterizing, until we measured success, right? In the patients who stopped catheterizing at 3 months, that success rate fell to about 20%. So what do we take from that? Well, I think really when you're doing CIC, what you're doing is a dilation. And so I think if you keep dilating, then you're going to prevent recurrence. But as soon as you stop dilating, the stricture is likely to recur. And so that tells us maybe a little clue about the fundamental, pathophysiology here is you're not really augmenting or modulating the treatment or the effect of the treatment. You're just treating yourself over and over again. And so I think though that from a clinical standpoint, this can be useful for poor surgical candidates or people who refuse urethroplasty. You can say, well, one option might be we do a dilation or a DVIU and then have you dilate. And then if you recur, we dilate you again, and so on. So not for everybody, but I think it's an important thing to know. So what else can we do? Well, many have used adjunct treatments to try to augment the success of endoscopic repairs. Here is kind of a busy slide with summary results from a recent systematic review in European urology. And this reviewed the literature, so systematic review and meta-analysis of adjunct treatments to endoscopic treatment for urethral stricture disease. And they, one of their exclusion criteria was they excluded studies that did not include a control group. And so these were just studies where they were comparing that against something else. And looking at the forest plot here, it looks like, well, first of all, so you can see what we tried. So CIC with steroid injection, mitomycin, either injected or infused into the lumen, hyaluronic acid injection, platelet-rich plasma, or even oral tamoxifen. And from looking at this forest plot here, you can see that everything anyone has ever tried worked. So that's called publication bias. And I think that, that being said, this is maybe a bit of an ambitious systematic review and certainly meta-analysis because these are small, very heterogeneous studies. So I think it's difficult to kind of lump them all together and come up with a definitive conclusion. But I do think that it's sort of proof of concept that adjunct treatments can modulate the effectiveness of endoscopic treatments. But I'm not sure about the author's conclusion that, mitomycin C is the way to go because, that had kind of more patients included. So they kind of drew the conclusion that mitomycin C had the, best evidence. I'm not sure about that, but I do think that it's a proof of concept that we can change potentially the urethra's response to endoscopic treatment, which is an important paradigm. So one kind of newer, most recent addition to the augmented success is this coated balloon, which the brand name for which is called Optoloom. And it's coated with paclitaxel, which is the same thing that we use to coat drug-eluting stents to prevent coronary artery restenosis. And so why paclitaxel? Well, it's an anti-proliferative, anti-fibrotic compound. It stabilizes microtubules and sequesters SMAD proteins, which ultimately interrupts TGF-beta signaling and by extension fibroblast recruitment and collagen production. And so this is pretty well laid out in coronary arteries. However, pretty limited kind of preclinical animal data in humans. Despite this, the balloon was already available, and so this led to a randomized trial to investigate the efficacy of Optoloom compared to non-coated kind of standard of care dilations. And so the name of this trial is called the Robust trial, and it's a randomized trial. And actually, we participated in this when I was a fellow at Iowa. And so the inclusion criteria, these are anterior strictures. And the key thing is these are recurrent strictures. So these are people who've had 2 or more prior endoscopic treatments, not urethroplasty, endoscopic treatments. They excluded patients who had hypospadias or lichen sclerosis. And the primary outcome measure was the ability to pass a 14 French cystoscope at 6 months. And they also looked at some secondary outcomes such as freedom from repeat treatment, IPSS, and Qmax. And so in the field, we call this, anytime you see this kind of a metric, we call that anatomic success, meaning is the urethra open or not? And if you kind of walk through this consort diagram, you can see that, they randomized 127 patients, 79 got Optoloom, 48 had a control procedure, meaning just a kind of a standard DVIU or dilation per the physician's discretion. And then, as with most clinical data, here's where you start to kind of run into some trouble. So a couple things to understand. First of all, there was quite a bit of crossover. So meaning that if patients had complained of a symptomatic recurrence, they were unblinded. The patients were unblinded. And I think that's a reason, they don't really talk about that in the paper too much, but I think that's a reason why you see these crossover events is you got a guy who's a month out saying, yeah, maybe my things are slowing down again. They unblind that patient and say, oh, you know what, you just got the normal dilation. And he says, well, I'm with the goods, so then he crosses over into the Optoloom arm, and that happened again, 8 patients at 3 months. And then, by the time we get to our 6-month window, we had 12 crossover events when they unblinded everybody. And so I think that's a significant kind of confounder. Even though they excluded those patients from the anatomic success category, there's still, you might imagine that there are some patients who got Optoloom who were unblinded who say, well, maybe my stream slowed down, but I know I got the experimental good treatment, so I'm just going to sit tight and see how it goes. And so they were kind of measuring different outcomes here, and I think that's a significant limitation of this. And so that being said, this is an industry-sponsored study, and so the cynic in me says, well, the industry got the Kaplan-Meier curve they wanted, which is that we showed at 6 months that 75% of patients treated with Optoloom, on average, were patent by cysto, and only 27% with standard treatment were. And so on the one hand, I think this is limited. On the other hand, I think this is probably real. I think that there's probably something here. It may not be quite as good as we see on this study, but I think that certainly as a proof of concept, it works. And the question is, what's the magnitude of that difference? And so this is now, again, an FDA approved option for treatment of recurrent bulbar strictures. I'm working on getting this, accepted here at UW so we can offer this to our patients. And I think it does fill a niche for patients who've wished to avoid or delay urethroplasty. So I think there's probably a role for this. So summary of endoscopic treatments. I think helpful for first-time treatments of short bulbar strictures, those who refuse or cannot have a urethroplasty, and I think dilation is the way to go over DVIU. And I think this concept of can we do a better dilation is a good one. I think that's probably where the future of the field lies, is can we improve the success of endoscopic treatments such that they're closer to urethral reconstruction. So let's switch gears now and tackle a few things about urethroplasty. So again, urethroplasty, kind of a broad term, encompasses a lot of different techniques. We certainly don't have time to discuss every possible technical variant. So I'm going to focus on two kind of principles and two specific operations that I do most of the time and explain why I do them. And so when you talk about urethroplasty, there's two broad categories. The first is anastomotic, in which we remove the stenotic segment and bring the two healthy ends back together. And then there's substitution, which is used usually for longer strictures, where we're not going to be able to get it to reach off tension, so we need to bring in some extra urethral tissue to augment the success of the lumen, or augment the caliber of the urethra. And so, we have some decisions to make. So in anastomotic repairs, we can do those in a transecting fashion, where we completely transect the sponge, or a non-transecting fashion. If we're going to do substitution, we have to decide, are we going to use a flap or a graft? And if so, where are we going to put it? Are we going to put it on the dorsum or the ventrum of the urethra? And so what I do is I almost exclusively perform non-transecting anastomotic repairs. I almost exclusively use grafts, and I usually put them dorsal. And so I'm going to explain the reason for that. And so here's how I approach kind of every bulbar case in kind of a systematic fashion. So first step is we make a perineal incision, we get around the urethra, and we make a dorsal urethrotomy. And then we look at the stricture and we make a decision. If it's amenable to an anastomotic repair, then we can do an anastomotic repair. And if it's longer, we can do a substitution repair. And that's a kind of a gross oversimplification, but I also think it's a good paradigm. And these are some of the factors that kind of weigh into that decision. So is it shorter? That would favor anastomotic. If it's more proximal, same. And is the blood supply good? Then I might think it's reasonable to either transect or kind of compromise the urethral blood flow with an anastomotic repair. Conversely, longer distal, or I'm not sure about the vascular supply, I'm going to strongly favor grafts. And so this is kind of the schema, or sort of how I think about it. So classically, the transecting anastomotic urethroplasty, or EPA, is a tried and true urethral reconstruction technique. And in this approach, the corpus spongiosum, as you can see, is completely transected. The urethral stricture with the associated spongiofibrosis is removed, and then the healthy ends are spatulated and reanastomosed. And so it's kind of crazy if you think about it that we can get away with doing that. And we get away with it for two reasons. First is the elasticity and redundancy of the bulbar urethra, which allows us to remove like 2 to 4 centimeters in most people. And the second is the robust blood supply. And so this is key. So let's talk about this for just a minute. So as you will recall, the blood supply to the penis and the urethra is based on the internal pudendal artery, which branches into the common penile artery, giving off the bulbar, urethral, corporal cavernosal, and dorsal arteries. And so if we transect the sponge, then this distal segment is relying on retrograde flow from this kind of dorsal blood supply and perforators, from the corpora. And so most of the time we get away with this because we transect here, we remove a little piece, we put it back together, you got good blood flow coming this way, good blood flow coming that way. But that's not always the case. And it's possible to devascularize the urethra and even the distal penis, which can result in reduced sensation, engorgement, cold glands, or even in rare cases, necrosis. And so I think most of the time you get away with this very clearly, but not always. And so you got to be really careful in patients with bad vascular disease, patients in this picture here with a prior hypospadias who don't have this arborization of the distal part, or if you really aggressively mobilize the penile urethra, you can significantly devascularize it. And so these are important principles to understand. So how can we apply these anatomic findings and maybe do a better operation? Well, in 2007, Jerry Jordan first described a bulbar artery sparing technique in which the bulbar arteries were encircled and preserved while performing an anastomotic urethroplasty. So he would still transect the sponge, but he would preserve the arteries, which is cool, but really hard to do. That's technically really challenging. Todi Mundy then published his technique in 2011 for complete non-transection of the sponge. And so this is the technique that I use for most of my anastomotic repairs. And in this technique, the strictures are approached dorsally. So here's a stricture, and then we're gonna through our dorsal urethrotomy, we're gonna cut out the strictured part and any associated spongiofibrosis. So we have this kind of bed of exposed sponge. And then you repair the ventrum longitudinally. So you reapproximate this, and then you close the dorsum in a Heineke-Mickowitz fashion with some interrupted sutures. And so by doing this, you're able to kind of achieve the same outcome without transecting the sponge. And so who cares? Do we really need to worry about transecting the sponge? Well, I think, cases of, like I mentioned, the kind of rare possibility of devascularization, that's rare. But what is maybe not so rare is changes in sexual function after EPA. And so the most frequently cited study on this is a meta-analysis from 2013 that found a 1 to 2% incidence. Again, kind of a meta-analysis of heterogeneous, not great data. And it turns out if you look a little harder and kind of ask the right questions, maybe this is higher than we think. And so Guido Barbagli in 2007, ahead of the curve as usual, studied his, a group of his patients for which he had good ED follow-up data, and found not insignificant rates of ejaculatory dysfunction, decreased gland sensitivity, and decreased engorgement. However, patients were overall happy, but when you ask, so they might say, yeah, I'm happy with the surgery, but if you ask them specifically about these things, they say, yeah, I've noticed that. That's been a problem. And so, probably higher than 1 to 2%, certainly. Two other studies kind of looked at this carefully. Erickson in 2010 and found a 38% rate of ED after transecting urethroplasty, but 90% of that got better by 6 months. And in both of these studies, they measured that as a five or more reduction in IIEF scores or patient complaint. And DAGRA, kind of similar, higher than you might expect, but most of it got better by 6 months. So Keith Rourke built on this by reporting his data after 352 urethroplasties, comparing success in sexual dysfunction as defined by a greater than 5-point change in shim. And he compared, or he looked back, sorry, it wasn't prospective, but he looked at non-transecting versus transecting EPAs. And he found a similar and high success rate between these two. However, there was a difference in sexual dysfunction. So EPA, when you kind of carefully question patients and follow them, there's a 14% rate of kind of global sexual dysfunction, again, defined by either patient complaint or a greater than 5-point change in shim at 6 months. So, to transect or not to transect, in my mind, I don't think we need to be quite as, melodramatic as Hamlet here. I think that, the equivalence, the success rate is equivalent as far as we can tell. And there's maybe a reduced rate of sexual dysfunction. And so I think it's also just usually not necessary to transect the urethra. And so my interpretation of that is that you should avoid it if you can. So switching gears now to the other types of repair. So the first repair, again, non-transecting anastomotic. Second repair, substitution with a dorsal onlay graft. And so again, just to review what we're talking about here. So if we're going to do substitution, we have to figure out what we're going to use, so either a graft or a flap. It's a long list of potential options. This is a simplified list. And basically, in the modern era, this boils down to buccal mucosa, oral mucosa grafts, or a penile fasciocutaneous flap, like a Makinich flap or an Urandi flap. And so the difference here is that grafts don't have their own blood supply. And so you have to rely on blood supply from either the corpora cavernosa if you put it dorsally, or the spongiosum if you put it ventrally. And flaps do have their own blood supply, so that's nice. So you don't have to worry about, is the graft going to take? So do we have any data on graft versus flap? So we do have a randomized control trial from back in 2007. This was 55 patients, 27 of which had a buccal mucosa graft and 28 of which had a penile flap. And they looked at, outcomes and then complications. And so in terms of outcomes, they found that buccal grafts had shorter operative times, about an hour shorter, and patients' satisfaction was higher with buccal mucosa grafts. And that's probably related to the complications. And so the buccal mucosa, the penile flaps had some penile complications, including some serious ones, such as superficial necrosis, skin loss requiring grafting, torsion, changes in sensation. And so patients don't like that. And so oftentimes that will kind of drive people towards an oral mucosa graft, which has a more acceptable or a lower morbidity, and certainly a lower kind of penile morbidity. What about dorsal ventral? Well, the Terns group was trying to have a randomized control trial to look at this question, but it failed to accrue, mostly because people kind of migrated towards dorsal approaches. And so we had to settle for a meta-analysis, which was performed in 2009, which showed equivalent success with dorsal or ventral grafts. Okay, so probably grafts better, or generally better than flaps, generally. And dorsal or ventral doesn't matter. So what should we do? So I think we put them dorsally, and there's two reasons for that. First, as I mentioned, it allows it sort of marries well with that non-transecting technique. So it allows a standardized approach to every bulbar case. You can dissect it dorsally, see what you got, make a decision. Also, I think it makes anatomic sense. The urethral lumen, you will recall, courses eccentrically through the corpus spongiosum, such that the dorsal spongiosum is thinner more proximally, or where we're usually doing our case. So this means that by opening it dorsally, you're cutting through a minimal amount of healthy sponge, which can bleed significantly. And also, you're opening the curve on its shorter side, which means you minimize the amount of distance you need to make up. And the corpora are a reliable, kind of excellent graft bed. So for those reasons, I think dorsal is the way to go. And if you need an example of this, you can just turn on the Olympics, because all of these skaters are kind of fighting to get inside. So they know the shortest distance around the track is the inside corner. So similarly, the shortest distance around the urethra is dorsal. And some other data, I certainly didn't figure this out on my own. It's part of a larger trend, and this is just a slide that I'll put up there, which are the results of an analysis of the large Terns database, which show over time a shift in the proportion towards kind of not a higher percentage of non-transecting repairs, shown in this kind of salmon color, and dorsal placement of grafts over time. So you can see that from 2010 to 2017, dorsal was kind of a it was done, but not so frequently, and then really kind of exploded kind of more recently. And again, this is from 2017. So I would speculate that this trend has continued since that time. So what does this look like in real life? Well, here's an example of a photo from a recent case doing a dorsal onlay. And so the concept here is that this is the graft. So the blue is the buccal graft, and what we're doing is, you can see the urethra shown in green is rolled over to expose the dorsal urethrotomy, and the graft is fixed and quilted to the corpora. And then what we do is we anastomose kind of this edge down like this, and then we put a catheter in, and then we do the other side. And so that's, for people who haven't seen like a dorsal onlay before, that's how you do it, as opposed to a ventral where you would just divide the sponge and then put the graft in. And then the key step there is you have to do a spongioplasty to provide a good support for the graft bed, which I think actually is kind of technically harder sometimes than doing a dorsal onlay. So anyway, that's a photo from a recent case. That's what it looks like when you're actually doing it. So let's briefly talk about outcomes here. So now that we've reviewed techniques for management, I'd like to leave you with two thoughts. First, that I love doing urethroplasty, but the success rate is probably not as good as we think, which is, EPA in excess of 90%, reported success, substitution, close to that, kind of 80%, 70 to 80%. So that's first thing, probably not as good as we think. And second, that endoscopic treatments may offer equivalent patient-centered outcomes to urethroplasty. And so this is a population-based study, kind of getting to the comparative or the efficacy of urethroplasty. And so they examined a large insured cohort who underwent urethroplasty and then looked to see if they had any additional procedures more than 30 days out from the urethroplasty and defined that as a failure. And so they found that, the group of patients who had anterior urethroplasty, 420 of them, was a 32% failure rate at their mean follow of about 30 months, which is certainly higher, than what we see in these kind of high volume expert series. And so certainly these are population level data, they're limited. We don't know the details of the strictures, the techniques used. It's a bit like saying, hey, we looked at everyone who had a nephrectomy and the overall survival was 50%. Oh my God, but the question is, well, how many of those patients had cancer or what was their stage? So on the one hand, a well done study with methodologic kind of limitations just from design, but I think it tells us that probably in the real world, urethroplasty is not as good as we might wish it was. And then the last thing to discuss is the only randomized control trial that compares urethroplasty and endoscopic management. And so this is from the UK, where they impressively were able to get over 200 patients to accept randomization for short bulbar strictures to either urethroplasty or endoscopic treatment, which is a feat. And so I think we got to pay attention to these data. And importantly, their primary outcome for this study was not anatomic success, it was patient-reported outcomes. So they looked at, using validated questionnaires, they looked at symptom scores, essentially, at 2 years out from their surgery. That was the primary outcome. And then their secondary outcomes were the more objective measures that we're more used to looking at in the field, like, can you pass a scope? What's your Qmax? Did you require any repeat intervention? And what they found was that there was no significant difference in kind of similar reduction in symptom scores after a DVIU compared to a urethroplasty for bulbar strictures. No appreciable change that they could detect. However, the objective outcomes were different. So the Qmax was higher. The chance that you needed a reintervention in the urethrotomy group was higher than in the urethroplasty group. And so I think these data, also in a comparison study looking at cost, they found that urethroplasty was more expensive, but results in a similar number of quality adjusted life years, which is interesting. And so I kind of leave you with, this thought, which is, I kind of talked about how I approach it. And then the question is, what are we really treating? And I think that, urethroplasty, unfortunately, is probably not as successful as we wish it was. I think it's a good treatment. I think it's a reliable treatment. But I also think we've kind of reached a little bit of the limits of what we can do with urethroplasty. I think we're probably going to be able to make it a little better. But my thought is that, this is usually a kind of more of a quality of life disease for most patients. And so if we can get them an acceptable, quality of life with a minimally invasive approach, then maybe that's not such a bad way to think about it, especially if we can figure out a way to augment the success of those endoscopic treatments to make them even just a little bit better. And so to review, I think bulbar urethroplasty is reliable. I think we should avoid transection. We should favor dorsal approaches. But probably it's not as good as we previously thought. And I think the truth is probably in the middle somewhere between the population level data and the high volume series. And so I think the future, I think we need to kind of come at this from a few different ways. First of all, kind of taking a more patient-centered approach. What are their goals? And usually patients' goals are, they don't really care what their Qmax is, they care about what their symptoms are. And so I think we have to at least think about that. But we also need to marry that with understanding the disease process, a little bit better so that we can come up with evidence-based kind of mechanisms for therapeutic targets to improve the efficacy of endoscopic treatments. Because I think that's probably where the future lies, is can we come up with better minimally invasive treatments that can approach the success we get with urethroplasty. I think a lot of patients given that choice, would choose a minimally invasive approach, even if it means they need to have more than one treatment. So that's all I got for today. Quick word of thanks to the group for your attention, and also to the team that makes all this stuff possible. So Laura, couldn't do it without you. Procedures team, thanks for letting me essentially operate on people down in clinic. Thank you for that. Emily, Jess, and Megan, my nursing team. Pam, scheduling, Debbie, administrative support, of course, the residents, and my partners. And then also thanks to these guys. So I think I gave grand rounds a year ago, and this guy had just been born, Elliot. Now he is big, and this is his Waldo impression here. And then Hadley just keeps getting bigger and bigger. So thanks for your time, and looks like we're out of time, but if there's any questions, I'm happy to answer them before we dive into Journal Club.
Great. Thanks very much, Matt. Questions for Dr. Grimes from the group?
And I have not a question, but a comment. That was a fantastic talk. And female urethral strictures don't come up that often, thankfully. But what does come up is mesh across urethras, at least in the last 15 years. That's a thing that happens. Or mesh eroded into urethras, or other stuff eroded into urethras. And certainly it has been a theory, but I think that you explained it nicely, that not fully transecting the urethra to get that out leads to better outcomes. So I will often do all kinds of maneuvers as much as we can to try to really just make two little small incisions in the urethra in the female world, particularly laterally, so that we don't increase our risk of developing a fistula, but also just to improve the functional outcome of that urethra after we do that. And I don't know that anybody probably has a big enough database to look at whether or not it makes a difference, but it seems based on this that it probably does.
Yeah, no, and I think that's a great point, and I think that's one problem with kind of benign urology in general, is that we're never probably going to have that data set, right? And so I think we have to kind of use the data that we do have, as well as just kind of good sense, kind of reconstructive sense, like, hey, we should preserve the blood supply. Hey, let's not cut the thing we're trying to fix in half if we don't need to. I think that those, not to sound like, pedantic about it or pejorative, but I think that, a lot of smart people kind of think about this, and when they arrive at the same conclusion and sort of vote with their feet, probably that's worth something, even if it's not a randomized controlled trial. So.
Thank you. There's a question in the chat. Were you gonna?
Yeah.
Sorry.
Yeah. It looks like there's a question in the chat from Jordan about following patients after dilations and urethroplasties. How do you follow them for how long? I'm flashing back to when Jerry Jordan was a visiting professor 10 plus years ago, and said that whenever he dilates someone, 6 weeks later, he does an office cysto to look for early versus late recurrence. That was a dogma back then. How do you follow your patients?
Yeah, great question. I actually had some slides on this, but I cut them for time. So I think here's what I do. After we do either a dilation or a urethroplasty, I scope that patient 3 to 6 months afterwards. And then if they are patent at that time, then I kind of take a risk stratified approach. And so if they're a dilation and I sort of expect them to recur, I'm probably going to scope them again, or at least do a uroflow in either 6 or 12 months after that, and kind of lay eyes on them again and make sure they're not having trouble. So dilation is a little different than urethroplasty. So for urethroplasty, kind of same. I do a cystoscopy in 3 to 6 months afterwards for either an anastomotic or a substitution repair. And then if they're patent at that time, I follow them annually with non-invasive uroflow and PVR and a UA, and kind of looking for complications or recurrence. And then if they've either recurred at that 3 to 6 month cysto, or I'm kind of worried about them, meaning like they had a substitution repair. So we know that substitution repairs, unlike anastomotic repairs, it seems that they're more likely to recur with time. So there's kind of a delayed recurrence phenomenon with substitution as opposed to anastomotic. And so I'll tend to follow those patients a little bit more closely. There's pretty good evidence that if you're open within the first year after an anastomotic repair, you're probably going to do okay. And so it's this kind of tough balance where, you know, I would love to do like Jerry Jordan and just scope everybody every 6 months just to know, you know, that would be helpful and good from a research standpoint. But a lot of times, you know, patients obviously don't want to have invasive testing. And also there's sometimes like an insurance issue too, where, you know, they'll come back and say, or I had one patient, you know, who, young guy working, coming from a distance, and he, you know, was like, hey, I came for this cysto and it was normal, and now my insurance company is saying they're not going to pay for it. So like, why did we do the cysto? I'm doing fine. You know, so I think those are kind of the two things you have to weigh. So what I do is everybody gets a cysto 3 to 6 months, and then if they're open, I follow them non-invasively. And then if I'm not sure, like the scope is a little bit of resistance or they got a UTI or something, I might do another cysto in them in 6 months. So that's my kind of my protocol, if you will. But that's kind of the way that I approach it. And then I do it to 5 years. Sorry, I do it to 5 years. So let's say we do urethroplasty, we scope them, they're open. I see them for a uroflow annually, and if they're still open at 5 years, I say congratulations, because I just don't think I can haul someone back into clinic who's doing well 5 years after an operation. At that point, it just doesn't make sense.
Great. Well, thank you so much, Matt. In the interest of time, we'll shift over to Journal Club in just a moment, but also thank you in advance for your time, Matt, with the residents in rec, and I'm sure they're going to have many more questions to throw your way in further discussion of urethral stricture disease.